Hi, everyone. My name is Vanessa. I'm a master's student at Dr. Shyh-Dar Li's lab in the University of British Columbia. And today I'm just going to be talking a little bit about my thesis work. So my project focuses on colorectal cancer. And colorectal cancer is the second most lethal cancer for men and third for women, according to the Canadian Cancer Society. So in the late stages of the disease, very common for patients to experience something called peritoneal metastasis. So the peritoneal cavity basically includes your abdominal cavity, and the organs that are in it are the liver, small intestine, stomach, the colon, a whole bunch of things. And basically, this is a very aggressive form of cancer. And the current treatment includes cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. So what this implies is the tumors that are visible are surgically removed, and then the abdominal cavity is flushed with heated chemotherapy drugs. So even though this treatment is very aggressive, most patients have a 76% chance of cancer recurrence within 5 years post-treatment, which means we definitely need to do better with our treatment. So the drug of interest that I will be introducing is called Resiquimod. So Resiquimod is an immune boosting drug that triggers the release of pro-inflammatory mediators and interferons. So within our body, we have chemicals called cytokines, and an example of this is interferon alpha. So what this can do is it can activate dendritic cells and increase antigen presentation in the tumor microenvironment. So for most patients, their tumor microenvironment is immunosuppressive, which means there is little infiltration of immune cells to go and clear out the tumor. So another thing is uncontrolled immune activation can result in something called a cytokine storm, which can result in heart damage and other sorts of organ damage. So it's very important that we are delivering Resiquimod in a targeted way to increase treatment efficacy and safety. So in order to do that, we're using something called liposomes, which are basically just nano-sized bubbles of fat. And the two formulations that I'm introducing are called DS-TAP R848, R848 being short for Resiquimod, and CPP R848. And as you can see, the size ranges from roughly 120 nanometers to 170 nanometers. So I'd like to bring your attention to the diagram on the right. And what's special about this formulation is that whatever is injected is retained in the peritoneal cavity. So from 0 to 24 hours, you can see that our DS-TAP formulation is retained in the peritoneal cavity, whereas the other ones go systemic all over the body. So here's the workflow for the experiment that we've been working on. So on day one, sorry, we're also working with mice. So on day one, we inoculate our mice with CT26 cells, which is a colorectal cancer cell line. These cells are allowed to establish in the peritoneal cavity for roughly 4 days, and then we do an injection of oxaliplatin, which is the standard of care chemotherapy drug for colorectal cancer. And what this does is it basically induces cell death. So we do have these tumor-associated antigens being released in the peritoneal cavity. Now, the next day, we start administering our liposomes with Resiquimod. And as I said previously, what this does is it activates the immune cells. And because we induced cell death previously, these immune cells can now pick up the tumor-associated antigen, present it to the T cells, get them to basically recognize what they're going to target, and that allows the T cells to go and infiltrate and then destroy the tumor. So moving on to the data, I have 5 graphs here, and I know it's a lot, but we'll walk through it together. So starting with graph A, we have our mouse model of peritoneal metastasis treated with only PBS. And as you can see, roughly around day 35, all our mice are euthanized because they're really not doing well. Moving on to graph B, we have 1 dose of oxaliplatin and then treatment with PBS. And once again, the survival is a tiny bit better, but really all mice are dead before day 50. So now moving on to graph C, D, and E. So the different colored lines represent different dosages that we use. And in graph C, we have our oxaliplatin combined with free Resiquimod, so no delivery nanoparticle. For our lower doses, we achieve roughly a 40% survival. And the interesting thing is that we do see 80% survival with this treatment, but our further experiments actually determined that this wasn't an ideal route of administration or route of treatment, but I'll get into that later. So graphs D and E represent our different liposomes that are introduced earlier, with DS-TAP R848 achieving roughly a 60 to 80% survival rate, and graph E representing CPP R848 achieving roughly 50 to 70% survival rate. I'd like to also clarify that mice are considered cured if they are surviving and tumor-free after 120 days. So based on the graphs, survival experiments that we've performed here, the DS-TAP R848 treatment was shown to be more consistent across the different doses, and that is a formulation that we are moving forward with. So as I explained in the beginning, recurrence is a really big problem for patients with peritoneal metastasis. So it is important that we figure out whether this treatment generates immune memory, and the patients that are treated won't basically have recurrence of their disease. So how we did this was with a subcutaneous rechallenge. And how this works is we inject the original tumor cell line on one side of the mouse's flank and a new tumor cell line as a control on the other side. So on to the data. On the graph on our left is our CT26 rechallenge. And this is the original tumor cell line that I introduced in the beginning. And we can see that our naive mice, so these are the mice that have never received any treatment, all of them developed the tumor before 15 days. The free drug treated mice, however, did see a recurrence, which is why we believe that our free R848 route of administration is just not as good in comparison. Both liposome treated mice didn't see any recurrence of CT26, which kind of suggests that all these mice developed immune memory from the original tumor and wouldn't see recurrence later on, which is pretty exciting. Now moving on to the 4T1 rechallenge, which is the new tumor cell line. All our naive mice developed this tumor. All of the free drug mice developed this tumor. But what was interesting was that the DS-TAP R848 treated mice had significantly better tumor rejection, even though the mice had never seen this tumor before. So that's very interesting. So yeah, going back to DS-TAP R848, we did actually want to optimize the dose regime to see whether the survival effect would also be better if we use fewer doses. So as a reminder, the graph on the left is what we explored previously with the different dosages. On our right, we have the DS-TAP R848 treated at 2 mg per kilogram across different doses. But as you can see, 6 doses is significantly better for survival compared to 4 doses and 2 doses. So that is what the treatment regime that we hope to move forward with. And this also tells us that the dose frequency is probably more important than the actual dosage itself for this formulation. So to summarize what I talked about today, we achieved an 80% cure rate with our optimized dosing regime and found that all mice treated with our formulations rejected the original tumor. Once again, this is important because patients with peritoneal metastasis of colorectal cancer have a roughly 76% recurrence rate within 5 years post-treatment. So the development of this immune memory is really important. Moving forward for our next experiment, we will be combining our treatment with PD-1 and PD-L1 antibodies to investigate the synergy between these two treatments. Both these antibodies are currently FDA approved, but they only yield a roughly 30% success rate. This is currently being used for patients that don't have really any other options, that they can't receive surgery or aren't responsive to chemotherapy. So we do hope to improve the success rate. Hey, yeah, on to acknowledgements. I'd like to thank my lab. Here's a picture of us. And of course, to NMN Canadian Cancer Society, UBC, and CIHR for funding this project. And yeah, thank you so much for listening. I will open the floor to any questions.
Great. Thank you very much, Vanessa. That's exciting science you're working on there. So, Vanessa, in terms of the dosage, you said the frequency might be more important than the dosage levels. But what do you think might happen if the dosage was increased above 2 mg per kg?
Right. So we did test this previously. I don't have the slides on me currently, but we did actually find a drop in survival rate. So instead of 80%, it went down to 70%. And I mean, it's hard to say whether that is actually significant, but what happens when you dose a little too high is sometimes your immune cells can become exhausted and they might just not work as well with this higher dose. But yeah.
Okay, thanks. And so the optimal, the amount of doses given per day or per period, what did you find to be the optimal balance in terms of administration?
Right. So from our previous data, we saw that 6 doses, the dosing regime that we went with, which is dosed every other day for 2 weeks, that gave us the 80% survival rate. Anything less than that didn't seem to be as effective. Um, we haven't done experiments for like everyday dosing, but also everyday dosing is really exhausting for the animals and of course for people as well. So ideally, we'd like to give them a break in between dosages.
Excellent. And Divya, it looks like you have a question.
Yes, very nice talk. Do you think this immunomemory is long lasting? Would a patient be protected from recurring cancer 5 years from the treatment, for example? Are you thinking on experimenting with that?
Right. So to my knowledge, I feel like the immune memory is pretty long lasting. Our challenge is actually with a pretty high dosage or high amount of cells. So the fact that they rejected it is a pretty big deal. Also, in addition to that, the experiment goes on for roughly 4 months. So 4 months in a mouse's lifetime is actually a lot of time considering these mice live maybe 2 years if they're lucky. So that is a substantial amount of time for them to have this immune memory.
Great. So Vanessa, it was interesting that when you reintroduced the cancer cells, some of the mice did not have a reoccurrence of the tumor, but the mice that were treated with the free R848 did. What do you attribute that to?
Yeah, that's a good question. So basically, the free R848 goes systemically all over the body and also isn't really retained in the peritoneal cavity where it needs to be. So there's a lower chance for the immune cells there to really develop, I guess, get activated and probably subsequently develop that immune memory. Um, so that could be a reason why they really just didn't have a better overall response. I did show in the diagram in the beginning that our liposomes did keep our drug in the abdominal cavity for quite a bit of time. So there's a lot of time for the immune cells to mature in this case. Yeah.
So it really speaks to the importance of targeting the drug and delivering it and keeping it in the tumor or the affected area of the body where the tumors are growing.